I'll first introduce Dr. Melissa Odell. She's one of our speakers for today. So Dr. Odell is an assistant professor of psychiatry at the University of Nebraska Medical Center. She's the founder and director of the Aspire Clinic, which is a multidisciplinary treatment team housed in the psychiatry department at UNMC, which is dedicated to providing evidence-based, recovery-oriented, person and family-centered care for people with psychotic disorders. She's an advocate for improving access to quality care for people with psychosis and currently serves as a delegate to the American Psychiatric Association Assembly. And then let me also introduce Dr. Brown Keebler. Dr. Brown Keebler believes that revolutionizing primary healthcare models to address cardiometabolic risk reduction is the key to improving both individual and population level health outcomes. She has collaborated interdepartmentally at the University of Nebraska Medical Center to establish a multidisciplinary team through the Active Support for Psychosis and Recovery, the Aspire program, to provide comprehensive whole person health care to people with severe mental illness. She's completing her Ph.D. through the UNMC Clinical Translational Mentored Scholars Program, where her focus is evaluating the intersectionality of mental health and health outcomes. Dr. Brown Keebler is actively involved in teaching and mentoring medical students and residents at UNMC with the goal of promoting clinical research and high-quality primary care. She is board certified in internal medicine, pediatrics, and lipidology with a clinical practice focused on primary care and cardiometabolic risk reduction. And I will have the great privilege to hand it off now to Dr. Odell and Keebler Brown. Thank you for your time today.
Yeah. All right. So can you guys see the presentation screen okay?
Yes, that's great.
Perfect. Let's flip it. Flip it. And we're going to swap here for a second, and then we're going to change what we're sharing. There we go. All right, so thank you all for having us today, and thanks for the introduction. We're really pleased to be here and appreciate the invitation, Dr. Sauer, and we also appreciate the coordinated efforts by Robin for letting us join you guys today. So speaking on behalf of both of us, we're really honored, and we're excited to share one of our topics that we're really passionate about. So our Aspire Clinic does have grants from the Behavioral Health Education Center of Nebraska and the Kim Foundation for Suicide Prevention. Hang on. I know there's one more piece that we had. Oh, and then I'm also a co-PI in the multi-site precedented study starting up here at the UNMC site here shortly. I have kind of a different type of disclosure to make. My father and my brother both suffered from severe bipolar disorder, and they were lifelong smokers and didn't really make a habit out of seeing any doctor aside from their psychiatrists. My dad died at age 57 and my brother Ryan at age 39. They were both really brilliant and charming men, and boy, did they know it. I always think they'd get a kick out of me talking about them in this kind of a setting. My dad's love of Star Trek is the inspiration for the Star Trek theme today, but I do think it's an apt metaphor for our topic, which is how to improve health outcomes in people with serious mental illness who have so much stacked against them. It's really easy to feel demoralized or like the situation is utterly hopeless. In Star Trek, the crew faces complex problems which often seem insurmountable. No matter how overwhelming the task, they never give up and they consistently work as a team. Excuse me. Each crew member has a designated role, and of course they're encouraged to play to their strengths based on that role, but also ready to give the assist to another crew member when the situation calls for it. Improving health outcomes for people with serious mental illness takes this kind of an all-hands-on-deck mentality and a relentless optimism in the face of obstacles. I'm really pleased to be able to present today with a colleague who shares that philosophy and passion, Dr. Brown Keebler. So our objectives today is really to work on formulating an approach to identifying and addressing cardiometabolic risk factors. We're going to spend our time really on high impact components. And I also want you to think about how you can use our tips that we're sharing with you today to improve communication with your primary care colleagues, as well as identify some initial steps that you can also take that you might not necessarily think of in reducing risk for this patient population. Just a little more background on our clinic, Aspire. So I founded the clinic in 2019 with the goal of offering the gold standard of outpatient care for people with psychotic disorders and raising the standard of care in the community. When I was growing up, my parents and grandparents owned and operated assisted living facilities that cared to people with serious mental illness. That's where I spent my holidays, lazy afternoons, and summer breaks hanging out playing bingo. Out of college, I got a job as a community support worker, and those experiences, as well as my own frustrations in trying to assist family members with psychosis and accessing high quality care, were what made me decide to become a psychiatrist and to found the Aspire Clinic. Our mission is continually to expand the quality of care and the services we offer, both for our own patients and to train the next generation of medical and mental health providers in best practices for the care of people with serious mental illness. For those of you who are acquainted with coordinated specialty care for first episode psychosis, per the RAISE trial in 2008, this diagram may look familiar. We do consider ourselves a coordinated specialty care program, though we currently rely on partnerships with community mental health centers to provide certain services we don't offer, such as supported employment, peer support. What's not part of the coordinated specialty care model, though, is primary care. Dr. Brown Keebler approached me in, almost 4 years ago now, about developing a reverse integrated clinic, and by July, she was meeting the primary care needs of our patients in the psychiatry clinic. Now we really can't imagine going back to not having integrated primary care on our team. The other thing that distinguishes us from a typical coordinated specialty care program is we see patients with psychosis across the lifespan. Now, the secret sauce of any treatment program is a recovery-oriented culture more so than the individual components of the programming offered. And we could have a whole talk on what that means, but here's one model that SAMHSA put forth. In a nutshell, it's an attitude. It's working with people, not doing things for or to them, and encouraging people to discover what they want out of life, to recognize their own strengths that can help them achieve those goals, and ultimately figuring out together what are the ways we can best support them as they pursue their hopes and dreams. It's recognizing a person is not their illness, and it's about building meaningful relationships with people we're serving and letting that relationship fuel the work. While our clinic is targeted at people with psychotic disorders, we're going to talk more broadly about people with serious mental illness today, where we have a stronger literature base with regard to health disparities. Here's the definition of serious mental illness per SAMHSA. You may have also heard the term SPMI, severe and persistent mental illness, which is kind of older terminology, but essentially the same concept used interchangeably. And of course, this is distinct from the idea of DSM-5 diagnoses. Any DSM-5 diagnosis can be classified as an SMI that's severe enough to result in psychiatric disability. Here's the latest data that SAMHSA has released on prevalence rates of serious mental illness in the US. And some things I want to highlight here in this data. There's a sharp age drop-off you'll see from ages 18 to 25 to 26 to 49, and again, 50 plus. Some of that we do believe is recovery, people who have no longer meet the criteria for having a serious mental illness later in life. But unfortunately, a lot of that is also premature mortality. The other thing I want to highlight in this data is the notably higher rates in multiracial and American Indian populations. So about 1 in 5 people has a mental illness, and a quarter of those has a serious mental illness. Prevalence rates highest, again, in 18 to 25-year-old age range. Now, SAMHSA has proposed a number of different models of recovery over the years, and this one's a simplified framework about the dimensions of recovery, which is kind of worth keeping in the back of your mind throughout the rest of the talk, to help us stay focused on the meaningful outcomes that matter to people and avoid losing the forest for the trees when we're working with people with really complex and sometimes overwhelming needs. Health, so overcoming or managing one's disease or symptoms. Home, stable and safe place to live. Purpose, meaningful daily activities such as a job, school, volunteer gig, family caretaking, or creative endeavors. And community, relationships and social networks that provide support, friendship, love, and hope.
All right, so we can address this in many different ways. I like to think about this in terms of multi-level risk. So as Captain Kirk said, risk is our business. That's what the Starship's all about, and that's why we're aboard. So we're going to think about individual level risk factors to address. We absolutely know that severe mental illness poses its own challenges. There are disorder-specific factors such as disease severity, family history, what symptoms this person is experiencing, age of onset, and so on. We also can think about individual level behavioral risk factors such as tobacco use, diet, physical activity, substance use, motivation. But we can also broaden this to a health system level. So what are the leadership policies and guidelines in place to help address the health needs? What finance and resources are put towards meeting these health needs? Information shared? How is delivery, the service delivered? So is there fragmentation, or is there co-location of services or integrated services? As well as thinking about the beliefs and attitudes of the people providing healthcare and how people communicate within the health system. And then finally, we don't want to forget about our societal level factors. As it should be a really hot topic, social determinants of health make a huge impact on the lives and health of our patients. So thinking about how we can design and improve public policies, such as discriminating policies, low protection, limited healthcare coverage, thinking about how we address socioeconomic position in terms of employment, homelessness, health literacy, as well as really trying to work at changing our culture and societal values with regards to stigma and discrimination. So premature mortality, as we've already mentioned, is a really big issue. So all of these risk factors at all of these levels result in a significant premature mortality. And we know that people with SMI are dying 10 to 20 years earlier than everyone else in the general population. These deaths are secondary to comorbid non-communicable diseases such as cardiovascular disease, COPD, and cancer, as well as infectious disease and suicide. And they deserve more. When we look at the association between serious psychological distress and mortality, this bar graph really gives us a clear picture of that. So this wasn't necessarily SMI or diagnosis driven, but they did the US did a survey of people with serious psychological distress measures. And so at the time of the interview is the orange bar graph, and they followed up over 2, 5, and 9 years to see what the all-cause death rates were. And clearly there was a difference between the two that was significant, and that those who had serious psychological distress had a significantly elevated mortality that persisted throughout almost a decade. When we look at disease-specific mortality, and particularly this graph of people with schizophrenia, which is reflective of a lot of our patients with SMI, the left side here shows individuals without schizophrenia, and the right side is with schizophrenia, and this was conducted in Canada. So clearly there's a difference between the pattern here. We see that circulatory cardiovascular disease is the #1 cause of death in people with schizophrenia. Second here, this dotted line would be neoplasms or cancer. And then the dashed line here, I'm not going to say colors because I'm a little colorblind, I don't want to get it wrong. But this is more respiratory illness, and then the green would be metabolic illness, which is pretty consistent with what we know. So how do we address this moving forward? So as we know, this disease, cardiometabolic disease, is the #1 contributor. It is contributing about 17.5% to 22% to the reduction in overall life expectancy in men and women respectively, if they meet criteria for SMI. Why is this? Primarily cardiometabolic disease, including obesity, type 2 diabetes, dyslipidemia, hypertension, metabolic syndrome resulting in myocardial infarction and stroke. The CATIE study found that a prevalence of metabolic syndrome increased throughout the course of treatment, about 35% in males and 50% in females. And we also know that people with schizophrenia have a greater prevalence of sedentary lifestyle, obesity, and smoking. They're less likely to receive adequate pharmacotherapy for hypertension and dyslipidemia, and they are seldom tested appropriately for glucose and lipid alterations. So this has resulted in a significantly elevated increased risk from the overall US prevalence of 9.9%. People with SMI have an 80% increased risk overall of these cardiovascular events, and they have a 2 to 3-fold increased risk of death. This is a topic that has been really important to me, but has become even more important the more I work with our patient population. This illustration really, I think, exhibits the challenges that our patients face within their disease and within the healthcare system and within society as a whole. They're kind of jailed in the situation that they're in, and it's hard to break out of the end game here of cardiovascular death. I'm going to tell a quick patient story. I had a patient, Marty, name change due for privacy purposes. One of the first patients I met when we started this clinic had a significant schizoaffective disorder, had a lot of social anxiety, found it very difficult to get outside of really more comfortable situations and scenarios. So would only come to the psychiatry clinic and home. Didn't go to the grocery store, would interact with really close family like mom and brother, but that was it. Over the course of the 2 years that I knew Marty, we were able to get him treatment for his blood pressure, his hypothyroidism. We got him treatment for COPD. He ended up disclosing alcohol use disorder, and we were getting him treatment for that. He was becoming more and more comfortable and establishing good rapport with our entire team, and it was incredible to see how he just changed with that whole experience with our team and seeing his health improve. However, he came in one day and told me that he had had a really rough week and he was visibly really distraught. His brother had died the weekend before of an acute MI. And I said, you know what, Marty, there's nothing we really need to handle acutely today. I'm so sorry, gave him a hug. Let's get you back in a couple of weeks and let's check in and see how things are going. A week later, Marty had also passed away of an acute MI. And I always wonder if we could have provided better health care for him sooner, would he still be alive today? Can't answer that question, but the answer is maybe yes. So ultimately, Marty needed a medical home with a culture where he could have hope and be respected as a whole person beyond just his psychiatric diagnosis and provide what he needed. So as we move forward, cardiometabolic risk is important. We need to have a systematic approach so we don't miss anything in evaluating and treating risk factors. We really want to have improved outcomes, and the only way we can do that is to be really thorough. So here's all the components, and we're going to go in order here about how we want to take actionable steps to reduce cardiometabolic risk in our patients based on our current review of the literature. First, we're going to talk about antipsychotic monitoring. I hand it over to Melissa.
And before we go into the role that antipsychotics play in cardiometabolic disease in people with serious mental illness, I just wanted to give a quick reminder, even though I suspect I'm preaching to the choir with you guys, that antipsychotic medications should be reserved for situations where they're actually required. This is a 2020 study about trends in treatment of bipolar disorder, which really highlights how the rates of second-generation antipsychotics skyrocketed in the 2000s, while lithium and Depakote prescriptions plummeted. I'm not suggesting that this is an inappropriate use of antipsychotics, but the decline in lithium utilization does concern me. But it's notable that 30% of antipsychotics are prescribed in primary care settings, very often for off-label purposes. So among the pitfalls in prescribing antipsychotics is that off-label use. These are not benign medications. They shouldn't be used for first line for insomnia, behavioral symptoms of dementia, or behavioral or emotional symptoms in children. But they are frequently used off-label, and that's part of a legacy of equally shady and effective marketing practices, which in 2009, Eli Lilly pled guilty and agreed to pay $1.4 billion for promoting Zyprexa for uses not approved by the FDA, first in the long-term care market and then in primary care offices. So that's just good to be aware of, especially when we're sometimes consulting with our primary care colleagues and reminding them to use these medications judiciously. Polypharmacy is a huge problem. Also antipsychotic polypharmacy. And of course, there are situations where antipsychotic polypharmacy is rational and makes sense, but those situations are rare. And almost 20% of people prescribed antipsychotics are prescribed more than one. Antipsychotic polypharmacy is associated with increased costs, hospitalization rates, and lengths of stay, as well as adverse effects, including mortality. As Dr. Brown Keebler just mentioned, the lack of appropriate monitoring for antipsychotics, which we'll get into in more depth in a little bit, is a huge problem. And finally, a paternalistic approach to prescribing is very common with antipsychotics, even in 2024. And I think physicians and psychiatrists in general tend to be pretty well trained in the art of shared decision making, but it's tempting sometimes to throw that out the window when you have people with serious mental illness, and especially those experiencing psychosis, which doesn't really work out well in the long run. So we'll talk more about how to really focus on patient-centered and shared decision making as well. So keeping that in mind, just a reminder about what does appropriate monitoring for antipsychotic medications look like. And here's the clinical practice guidelines that are jointly released in 2004 by the American Diabetes Association and the APA. And there are different guidelines from different organizations, but in clinical practice, the rates of screening for metabolic markers are so low as to make these distinctions between one organization and the other pretty irrelevant. So there are some guidelines that suggest more frequent monitoring for high-risk antipsychotics, such as olanzapine and clozapine. One review and meta-analysis of the effective guideline publication on metabolic risk screening found 56% of patients being screened for glucose and 29% on lipids. So again, we have a huge guideline to practice gap here, and it's a big problem. A systematic review of studies of interventions that address metabolic screening of adult patients taking antipsychotics was recently done in 2012, and that found that a social influence to shift providers and health organization culture to encourage metabolic risk screening was a common strategy, as were clinical prompts and monitoring tools to capture provider attention. Relative to comparison groups, the interventions were associated with an increase in median screening rates for glucose from 28 to 65%, and lipids from 22 to 61%, weight from 19 to 67%, and blood pressure 22 to 80%. In our clinic, we selected lipid monitoring as a quality metric 2 years ago, and the advocacy of one of my colleagues here on our team, and saw the rates go up quite precipitously over the course of a year. We weren't able to get the BPA, which would have been really helpful in EPIC, but still, just with the culture shift and talking about this metric at our department meetings, it got us all kind of brought it top of mind for everyone and helped us be more accountable for doing our very best to get appropriate screening. And I have to mention here, I have a suspicion that one of the reasons that we as psychiatrists and other psychiatric providers tend to do a poor job of metabolic monitoring is that I think we unconsciously don't always want to know the answer because we don't really know what to do when we don't like what we see on labs or vitals. We don't really feel empowered to meaningfully impact those risk factors. So it feels bad to find out, oh, this person has hypertension, this person has hyperlipidemia. There's all these things that need to be addressed, and I don't feel confident on how to do it. So that's what the rest of our talk is really about. Of course, one of those ways you can intervene is by considering which antipsychotic you're using. And we do have really good data on the relative risks from a metabolic standpoint of different antipsychotics. This is a systematic review published by The Lancet in 2020 of 18 antipsychotics. And this heat map here shows how they rank against each other according to degree of alteration in weight, BMI, and metabolic parameters. The numbers reflect their P-score, ranking them on a continuous scale of 0 to 1. Probably a little bit more information than you need, but it's out there if you wanted to primarily look at that to try to make a clinical decision. Here are kind of just the quick and dirty. If you were concerned about a particular metabolic parameter, this is what the monthly prescribing guidelines would suggest that you might try switching to. I also just wanted to mention about the new drug without dopamine activity that was recently approved by the FDA, Cobenfy, which combines xanomeline, which is a dual M1/M4 preferring muscarinic receptor agonist with a peripheral muscarinic receptor antagonist, trospium chloride, to try to reduce adverse events related to peripheral muscarinic receptor activation. It's kind of hard to say long-term what this is going to look like from an effectiveness standpoint because right now we don't have the clinical practice to back up the trials look good. But from the standpoint of adverse effects related to, they were similar to placebo in the trials that we have. So this could be really exciting in the future. Time will tell. And the efficacy question is really important when we think about making medications choices for psychosis, and the decisions that's usually driving the decision more so than the safety profile, if we're being honest. So in that regard, I just wanted to share a quote from a letter to the editor from the New York Times, which was written by this woman here is Pamela Spiro Wagner, and that's her. And this is a book that she wrote with her sister, and she was attending medical school when she developed schizophrenia. And in this letter to the New York Times, she wrote, "Zyprexa is a miracle drug for some of us. It opened up the world, allowed me to read and feel a crackling enthusiasm for life for the first time in years. And it cut down drastically on the voices and strange thoughts. Zyprexa was also the worst drug I've ever taken, making me gain 65 pounds, adding 100 points to my cholesterol, and raising my triglycerides sky high. I was both ecstatic to be involved in the world and miserable, obese, and unhealthy. I miss Zyprexa." I have to mention also the combination drug olanzapine samidorphan, known as Lybalvi, which was developed to try to address the metabolic effects of olanzapine. And unfortunately, while it's been found to decrease olanzapine-induced weight gain, it hasn't been shown to decrease any of the other metabolic adverse effects of olanzapine therapy, such as dyslipidemia and type 2 diabetes.
So as we've clearly laid out a case, we are concerned about the effects of antipsychotics, but can we place all the blame on the medications? We know that there are effects of metabolic syndrome, including central adiposity, insulin resistance, higher incidence and prevalence of type 2 diabetes. We're not going to go into in depth about other medications, but of course we can't worry just about antipsychotic medications. Among mood stabilizers, valproic acid is notorious for significant weight gain, and some antidepressants can also cause substantial weight gain, as well as some other metabolic derangements. A systematic review about metabolic adverse effects of psychotropics was published about a year ago if you're interested in learning more, and we've included it on a works cited page that you can reference after our presentation. Keeping in mind, though, if you look at people before they've ever been placed on an antipsychotic medication, even drug-naive first episode psychosis patients already have at baseline impaired fasting glucose tolerance, insulin resistance, and dyslipidemia. And then even looking at a more socioecological model, socioeconomic deprivation is an independent risk factor when calculating cardiovascular risk, as it accounts for poverty effects as well as social isolation. So the answer really is going to be kind of answered here in this graph. So this was a 20-year follow-up study of physical morbidity and mortality in relationship to antipsychotic treatment. It was a nationwide cohort of patients with schizophrenia, and they compared survival probability between those who had been compliant with their antipsychotic medication, which is the lighter line on the top, as to those who were not. And there was a significant improvement in survival for those who were on their antipsychotic medications. So ultimately, we cannot place all the blame on the medications. They are only a piece of the puzzle, and we need to look at a bigger picture. So next, we're going to talk about hypertension management, which I know makes every psychiatrist a little bit nervous. However, as a psychiatrist, you can intervene here. You can coordinate with a primary care provider. You can connect with a primary care provider and then become familiar with hypertension treatment guidelines, have a bidirectional communicative relationship. I would argue that any physician, including psychiatrists, can provide at least starting appropriate treatment for hypertension. And it really truly is going to take all of us stepping into roles that we might not feel comfortable with to address these high impact cardiovascular risk factors. So this all hands on deck approach. So first step, other than just deciding you're going to take this step, is making sure that blood pressure is assessed at every clinical encounter. This has been something that we've encountered here, that rooming staff don't necessarily understand why blood pressure is important, because it just seems to be a normal everyday thing. But it's good to see what's happening, making sure we're collecting it appropriate, measuring it appropriately. Next would be, are we meeting the appropriate parameters? If you have a blood pressure greater than 130/80, it might be good to repeat it, maybe keep an eye on it, start having those conversations with your primary care colleagues and think about, do I need to take another step here? Next, you could consider an intervention. Absolutely, you can consider non-pharmacologic interventions as well as pharmacologic interventions if you felt empowered to do so. And then finally, I continue to emphasize this, open up those communication lines with primary care providers at your institution. So things to keep in mind for non-pharmacologic interventions. These are counseling topics that you can talk about with your patients. Weight loss can result in significant reduction of blood pressure. Really focusing on healthy diet, the DASH dietary pattern, or combination MIND diet, which is DASH and Mediterranean diet. You can get good talking points from those to talk about simple, healthy lifestyle changes. Trying to help people reduce their dietary sodium intake. As well as really kind of trying to encourage combination of aerobic and anaerobic exercise. And then as well as moderation in alcohol intake. All of these together can at least be an additive effect on reducing blood pressure parameters. And then finally, I'm not going to spend a whole lot of time on this, but we do have it provided in the citation guidelines. You can be familiar with what we do as internists and family medicine docs on the pharmacologic approach to blood pressure. So normal blood pressure will be less than 120/80. Always optimize lifestyle habits that are healthy. If you have elevated blood pressures, you can talk about more lifestyle changes and continue to reassess. And then once you get into these higher blood pressures around 130 to 139/80 to 89, you can follow the algorithm and consider pharmacologic therapy if non-pharmacologic methods are ineffective. And then finally, for stage 2 hypertension, if you're consistently seeing blood pressures greater than 140/90, you really need to consider both the non-pharmacologic approach and a blood pressure lowering medication. So we've included the guidelines in our citation reference, and I'm always happy to answer questions for anybody. But I would recommend trying to get familiar with this and see what you can implement realistically in your practice. Next, we're going to talk about insulin resistance management, which can be a little complex. So we know that this insulin resistance cycle can be a vicious cycle, particularly on our medications, which is, I think, where the medications really come into play. So insulin resistance can be defined really as you have carbohydrate intake and you're entering into this metabolic cycle. Your pancreas releases insulin. However, in insulin resistance, you have a low sensitivity to insulin messaging. You have a resultant increase, disproportionate increase in high blood glucose. And then the glucose gets stored in adipose tissue and you have increased adiposity. This is further complicated by what an underlying person's genetics look like, what other medications they might be on, what their physical activity looks like, as well as what was their baseline weight and how quickly are they gaining weight, what's happening here. So ultimately, we've been kind of limited on how we manage insulin resistance in this patient population, but thankfully it is changing. We always want to emphasize lifestyle changes, and we'll have some tips and tricks on how to do that realistically towards the end of the presentation. We can use metformin, particularly early on in prescription of our antipsychotic medications to mitigate some of the weight gain and try to slow progression to type 2 diabetes. However, now we have GLP-1 agonists, which have been really exciting, and we're seeing more and more come out on these drugs every month, I would say, which I think they're going to be probably our future. And then in certain situations, weight loss medication may be applicable. So here's a list of our current available GLP-1s: dulaglutide, exenatide, semaglutide, liraglutide, and tirzepatide. I feel like I should make a poem about that. So obviously super popular. We hear about these all the times. They are certainly a safe option to use. It is difficult to get coverage for these medications depending on insurance plans, as I'm sure you have experienced if you have tried to prescribe these yourselves or working with primary care providers. You can absolutely almost always get them covered if a patient has type 2 diabetes, so A1C of 6.5% or more. But we are starting to get coverage for people with medication-induced obesity, particularly if they have a BMI of about 35 or more. So there are a few references that you can look at our reference guide that are looking at these specifically in our patient population. There was a case study that was reported in 2022 that showed that semaglutide was effective in type 2 diabetes and obesity treatment in schizophrenia. There is a study that's in progress, and it is a placebo-controlled, randomized controlled trial. The protocol has been published on the effect of GLP-1 receptor agonist semaglutide on metabolic disturbances in clozapine-treated or olanzapine-treated patients with schizophrenia spectrum disorder. So I'll be really interested to see those results. And there's also a really nice review that was just published this year. It's called the GLP-1 receptor agonist and weight loss in schizophrenia, past, present, and future. I think it's a nice read. Right.
All right. So when we broke down the different topics and who was going to talk about what, I initially wanted Dr. Brown Keebler to talk about lipid management, and she reminded me that part of the whole point of this talk is to get people more comfortable doing things that they're not comfortable with because the clinical situation demands it. So here we are. Oh, excuse me. This is just a breakdown of, oh, I lost my notes. This is like my worst nightmare. So when we're looking at it's not as complicated as it looks is the point. We're going to, and I think we actually went, look at the lipid profile, determine the overall risk factor, decide if we're looking at a primary prevention situation or we're already looking at having to look at secondary prevention and start the indicated therapy. We're just going to review what are the baseline normal lipid profile. And just remember that people with schizophrenia spectrum disorders have been found to typically show a profile of relatively normal LDL and low HDL, elevated triglycerides, even again at first diagnosis, even prior to any derangements induced by antipsychotics. And of course, then that tends to worsen over time with treatment. So that's challenging, but also keep in mind, if you have challenges getting people to take or to have labs drawn and comes down to a choice between, do I have to have you come back fasting or just do it now? Because fasting's probably not going to happen. We would always rather have some data to go on. So we often end up getting non-fasting labs in our clinic and just having to accept that there's a big asterisk next to that triglyceride level. So we have a tool here, the ASCVD risk calculator. I'd encourage you to check it out because it is pretty user friendly. If you have a minute in clinic and you want a little bit more concrete guidance on what to do. So if you just wouldn't mind just taking a moment right now and scanning this QR code. There's also an app you can download if you find that this is a useful tool for you and you'd like to just have it ready at hand.
So one of my really areas of interest that I really like to nerd out on is how do we predict cardiometabolic risk in these high-risk populations? A really interesting model that's been done and studied in the UK is the Primrose model. And so what they did is they took what we traditionally use as the Framingham risk model, which includes these traditional risk factors of smoking, LDL cholesterol, blood pressure, things like that. And they included some other factors. And what they saw was that they had a better risk model prediction. So they included social deprivation, which I've already mentioned earlier as an independent risk factor for cardiovascular risk. What the specific SMI diagnosis was, antipsychotic use categorized by risk, alcohol use, and BMI. And you can see here that the Primrose model, particularly in men, was significantly different than the published Cox-Framingham model. So really thinking about how do we do a better job of assessing risk and calculating risk so that it helps prompt us to intervene at an appropriate time. So ultimately, we can identify risk factors, including all of these. These are simple things that we can gather. We can assess risk in each age group based on what we have available. So some 20 to 39-year-olds do have a risk of ASCVD and a history of ASCVD. With the calculator, you can calculate a lifetime risk. And then over age 40 to 75, you can assess if they have a history of ASCVD and then estimate their 10-year risk score. And this will drive how you want to address treatment or conversations that you're having with primary care docs. I would say they'd be really impressed if you started talking about ACC scores. So this is a complicated at times, if you're not familiar with it, algorithm on how to assess risk and what to do about it. I'm not going to spend a super long time on this, but you can see this is kind of divided at first by age categories. We're always emphasizing healthy lifestyle guidance, thinking about family history, looking at what their persistent LDL cholesterol is, and keep in mind this is people that have not had an event, a cardiovascular event, and they do not have diabetes. So when we particularly get to these older ages of 40 to 74 without diabetes, this is when we really want to use the ACC calculator the most. So you can calculate and get these 4 different categories of low, borderline, intermediate, and high risk, and it kind of guides your conversation. And then up here, if you have significantly elevated cholesterol greater than 190, you definitely want to start treatment. Diabetes, you can risk stratify between moderate and high intensity statin therapy. And then there are these other risk enhancers that potentially could be included on future algorithms in calculating the risk scores, including family history of premature ASCVD, chronic kidney disease, the spectrum of metabolic syndrome, particularly in women, have they had a history of preeclampsia or premature menopauses, inflammatory diseases, things like this. So these don't necessarily help you calculate a better number, but it can maybe help influence your conversation and in your shared decision-making with your patients. And just as a quick reminder of what we consider high versus moderate intensity statin therapy, most often these days we're using atorvastatin or rosuvastatin. Some people are still on simvastatin, and I honestly probably have at least a couple of people still on lovastatin from previous physicians, and their cholesterol looks fine, so I keep them there. But really what we're trying to do is for moderate intensity statin therapy, we're trying to lower their cholesterol, their LDL cholesterol specifically by 30 to 49%. And then high intensity, we're trying to use these doses to achieve a greater than 50% reduction because these have been shown to be associated with significant risk in cardiovascular outcomes. All right.
All right. On to one of my favorite topics to discuss here. Oh, it froze. Screen. There, thank you. So smoking is the most important predictor of 8-year mortality related to cardiovascular disease in SMI. Analysis in 2017 concluded 62% of people with schizophrenia and 37% of people with bipolar disorder were current smokers, compared with 17% of those without a psychiatric disorder. And they also smoke more heavily than smokers without SMI. Due to a host of reasons, though, people with serious mental illness are less likely to be offered assistance with smoking cessation. Let's talk a little bit about why that might be. And first, I wanted to put a quote on smoking, but couldn't find one in Star Trek. And it turns out that the creator, Gene Roddenberry, who was a heavy smoker himself, thought that smoking would date the show. He felt enlightened future humans wouldn't have addiction, so they withstood pressure from the advertisers and never showed character smoking. I just love that story. Already obviously a Star Trek fan, but the disparities in rates of smoking between those with and without a serious mental illness stem from a number of factors I want to talk about briefly before we talk about practical tips to address that. The tobacco industry specifically targeted this population, and psychiatric hospitals have long supported smoking among patients. That, of course, is trending downward in recent years, but cigarettes used to serve as incentives for attending programs, taking medications, following rules. And those smoking bans that have come into place in more recent years, we still have to remember the legacy in a lot of mental health settings where people congregate of really supporting a culture of smoking. There's health systems factors that reduce access to medical care. And I think this is a big one. And obviously, one of the reasons we wanted to talk with you all today is because there's a lot of attitudes among us as healthcare professionals that really limit the opportunities for people to be offered smoking cessation interventions because the healthcare professionals themselves have a sense of hopelessness about it. And then there are social and biochemical factors. So I know, yes, it is more difficult to quit nicotine because it can provide temporary amelioration of symptoms of mental illness and increase difficulty managing those nicotine withdrawal symptoms. But I want to take a moment to correct a myth here that people with schizophrenia are self-medicating with cigarettes. That's a hypothesis that was actually invented and propagated by the tobacco industry, which funded most of the research in that area and only published that which supported the hypothesis. Yes, it's more difficult for people with serious mental illness to quit due to all these factors, but people with serious mental illness who do quit report improvement in symptoms, including anxiety, depression, and stress, with improved quality of life and mood. So let's talk a little bit about smoking cessation, pharmacotherapy, and always remember a combined approach tends to be most effective. And also what the patient is willing and interested in doing is always a good idea to start with that. But I try to encourage multiple forms of nicotine replacement therapy, as well as pharmacotherapy to reduce the cravings for nicotine. So we'll talk a little bit more about Chantix specifically, but in general, a long-acting nicotine replacement such as the patch, along with something supplementing with short-acting, depending on the patient's preference, is always a good idea to encourage to have more than one method, as well as making sure that you're actually talking about past quit attempts and what worked for them before and didn't, and building on those, what they've learned from that experience.
So one of my soapboxes that I get on is I get a lot of questions, well, is varenicline safe for our patients? And the answer is yes, it is. So this particular study is the EAGLE study, and it looked at neuropsychiatric safety and efficacy of varenicline, bupropion, and nicotine patches in smokers with and without psychiatric disorders to ultimately answer the question, is it safe? Is it causing problems with neuropsychiatric effects? So there was a quota of varenicline, 1 milligram PO/BID, bupropion, 150 milligram PO/BID, nicotine patches, 21 milligrams per day with a taper in comparison to a placebo. There was a 12-week treatment phase followed by a non-treatment 12 weeks, 15 face-to-face visits and 11 telephone visits, including tobacco nicotine use questionnaires, expired air carbon monoxide measurements, neuropsychiatric adverse events interview to document outcomes. And they had a monitored treatment compliance of about 80%, which I thought was pretty fabulous. But this is also a really aggressive program, which in my mind argues that we should be having more aggressive programs to have better success. So what did they find? They found that there was no significant increase in their primary endpoint of incidence of composite moderate to severe neuropsychiatric adverse events. And for their efficacy endpoint, they had varenicline was shown to have superior efficacy as measured by biochemically confirmed continuous absence for weeks 9 to 12. Bupropion had a similar efficacy to the nicotine patch, and everything was better than placebo. So I think the take-home message for this is these medications are safe, they can be effective, and we should be using them. Ultimately, in 2016, which now is almost 10 years ago, the FDA removed the black box warning from varenicline's label, which I consistently have to repeat with my learners in clinic. This is safe. There is no black box warning. We need to be doing a better job with treating tobacco use. Then the question is asked, well, what about psychotic disorders? There was about a 10% inclusion cohort in the EAGLE study. So this particular study is a systematic review and meta-analysis answering the question, well, is pharmacologic interventions for smoking cessation with people who have schizophrenia spectrum disorders safe and effective? It included all of the same drugs that were in the EAGLE study. It included people with schizophrenia or psychotic disorders who were smoking at the time of recruitment. They looked at a primary outcome of smoking abstinence and a secondary outcome of neuropsychiatric effects and safety. They found that all three medications were more effective than placebo, and there were no increased negative neuropsychiatric adverse effects, and it was considered to be safe. Again, combination therapy seems to be producing the greatest results, and low quit rates were demonstrated, as we all know, compared to the general population, even in the placebo group, which is really interesting. But ultimately, we still need some better studies in our specific patient population about more comprehensive programs. And sometimes that can be really complex to design a study for that, but I think it's definitely needed. Let's see, making sure we're getting everything. Okay, there we go.
All right, so we've grouped physical activity and dietary patterns together because the focus on this last section is really more about principles of talking to people about behavior change than on specific guidelines. This is the sign that's up at my physical trainer's gym, and I want to think about it both in regards to our patients who are trying to change and to us who are trying to counsel them on change. For both parties, it's really hard, but it's really well worth the effort. When you're counseling on behavior change, it's only going to go well when we have compassion for what makes it hard for our patients and also help them develop that self-compassion. Because most of the time there's a lot of really deep shame and internalized stigma about obesity or unhealthy habits that make patients hate themselves. And in addition to being very sad, it's just not a stable foundation for long-term behavior change. So I wanted to just talk through some high-yield tips for motivational interviewing. And to read more, please read it's probably my favorite book. That makes me sound like such a dork, but this is kind of the motivational interviewing Bible, and just some high-yield tips is stay curious and non-judgmental in your conversations, recognize the barriers to change and troubleshoot with patients. Try not to be the one doing all the talking when you're having these conversations, but rather try to get them talking about what are their reasons for change, and elicit commitment for those SMART goals that are specific, measurable, achievable, relevant, and time-bound. And then we're going to talk a little bit more concretely about what this might look like in exercise versus diet, but also just remember the teeny tiniest positive changes you want to really reinforce. Somebody who just says, I ate an apple, from someone who hadn't had fresh fruit as part of their diet in a long time is a pretty huge accomplishment. So some of it when it comes to exercise, it can be helpful to write an exercise prescription, but it's important not to necessarily get too bogged down in the guidelines. Keep them in the back of your mind. But not all patients are going to respond well to that kind of education off the bat when their behavior is so distant from those guidelines. Start by assessing where somebody is at and come figure out what is something that they can commit to and really feels doable for them based on their unique life circumstances, and join with them in making a plan that they can commit to and you can follow up with next time you see them. Also remember, exercise often doesn't lead to weight loss on its own, but any increase in exercise reduces mortality with additional benefit from more active movement. Consistent exercise has been shown to improve neurocognition, patients with serious mental illness, and decrease incidence of comorbid depression. So it's definitely worthwhile to help people focus on just the act of physical activity, apart from any impact it may or may not have on their weight. To the point that there's exercise, which is fantastic, but there's also just reducing sedentary behavior, and that can be very effective as well. Sometimes that's where we're starting at. So people with serious mental illness, especially major depression and schizophrenia, are much less likely to engage in exercise and are more prone to sedentary behavior. And the negative health effects tend to be markedly worse at lower levels of physical activity. So they have a lot of barriers to engaging in physical activity. And we really want to just help them recognize their own internal motivation to try to start overcoming some of those barriers. So it can actually be helpful at the beginning of that process if amotivation is a symptom that's likely to interfere with all these grand plans to just explain the cognitive model of behavioral activation to try to get some buy-in. And it's pretty simple. Do less, avoid. You're going to feel better immediately and worse in the long term. Do more, even if you feel like doing less. Force yourself to do it, kind of the opposite action. I don't feel like doing anything, but I'm going to do it anyway. In the immediate reaction is to feel discomfort, and you'll feel better in the long term. So just very explicitly explaining those two cycles to people can be a useful framework for the conversation about what am I willing to do to improve my lifestyle. And if you have your own way of explaining that, of course, use it, but this is something that works for me. When it comes to nutrition counseling, again, a lot of barriers in this population, and people with serious mental illness may need more education about what a healthy diet actually looks like than other patients, just lower health and nutrition literacy. So education is helpful, but they're also going to have a lot of other barriers that we have to address. They may have low access to healthy food based on living in a food desert, may live in low-income housing neighborhoods with poor access to healthy foods and have limited transportation. So the gas stations of acting as their grocery store, likely to live on a fixed income, which may impact their ability to buy fresh fruits and vegetables. Or they may even live in a congregate setting like an assisted living facility or halfway house, et cetera, where they don't have a lot of choice in the foods that they eat, and they have to, and those settings may have fixed budgets where they're buying cheap calories. So that we have to keep that in mind and make those plans that we make with the patient really specific to their life circumstances and meaningful, instead of just giving guidelines that they're not able to implement meaningfully. They may, those who live independently may have a lot of challenges with cooking, executive functioning deficits, and amotivation, make it difficult to cook food at home, increase the likelihood of eating fast food or convenient foods. And of course, the increased appetite with many antipsychotics is just another factor, a carb craving that can be associated with a lot of medications we prescribe. So this is important to acknowledge those barriers and really validate their experience, while also eliciting some motivation to try to work towards whatever small steps they feel they could make that are going to be sustainable for them. I also want to briefly note here, bariatric surgery is a viable option, and weight loss outcomes are comparable between those with and without a serious mental illness. So with any intervention we discussed today, whether it's a medication or a behavioral intervention, it's the foundation is a strong relationship with the patient. It's also critical to involve the patient support system so everyone's on the same team. In patients with serious mental illness, that support system might include family members, a guardian, a caseworker, maybe an AA sponsor, a group home staff member, whoever it is, all hands on deck.
All right, so we're going to wrap this up. You may find this familiar in some of the terms that we discussed earlier, but again, thinking about this on multiple levels and how we want to address this. We've focused a lot of time on individual factors, on how we address management of the underlying mental health disorder, choosing appropriate medications, assessing individual risk factors, and addressing those risk factors and behaviors, but also really broaden how we approach this, methods to approach this as far as a health system. How do we advocate for policies to be put in place to standardize screening in these high-risk populations? How do we establish well-funded care coordination and collaborative care strategies, as well as thinking about, can we integrate delivery of mental health and physical health care? And then finally, the societal level, thinking about how do we address ultimately these social determinants of health that can be quite complex, but what can we make an effect on? So thinking about social support, have establishing peer programs, family programs, advocacy groups, really advocating for stigma reduction as a society, and then really advocating and voting for policies that include comprehensive healthcare packages, equitable health care insurance, public health programs, supportive employment, housing, and social welfare. So our take-home messages to finish up here is that clearly we know there's significant health disparities that lead to premature mortality in people with serious mental illness. These factors abound. There's so many of them, and they are contributing on multiple levels. But we can approach this systematically and identify areas where we can make a change and make difference, particularly as it stands with cardiometabolic risk, it is possible to intervene here and have some better outcomes. And ideally, if we consistently do this, we can see some improvement in mortality rates. We want to emphasize that keeping a recovery mindset maximizes autonomy for this vulnerable population, and we want to continue to utilize shared decision-making skills. And finally, our all hands on deck approach. I know you're probably tired of us saying that, but it takes everyone and it takes all of us with overlapping roles, open communication, consistent messaging, old school hallway conversations, not just relying on EHR messaging, and continuing to include social support systems in conversations. Thank you for having us.
Awesome. Thank you both so much for the conversation. It's been a really amazing array of resources. Thank you for sharing also the handout that Robin has posted in the chat. Yeah, so I see we have a couple hands up. We also have a couple questions in the chat. I'm wondering if we can maybe just start quickly with the chat. I don't know if you can see, but first question was from Dr. Shadid about, would you recommend always starting metformin upon initiation of any second generation antipsychotic? Kids and adults recently had heard this is suggested for kids and teens.
I think that's reasonable, particularly for your patient that you consider to be a more high risk. So for those people who already have poor health behaviors, who already have higher BMIs at baseline, I think it's a really good idea. Absolutely. And it's as a pediatrician, or like half myself as a pediatrician, it's certainly a safe practice for kids as well.
Thank you. Okay, Dr. Matheson, if you can just hang for one more. Dr. Rose had asked, what do we know about GLP-1s, how they affect absorption of psychotropics?
I am not aware of any objective information on that, and I think it's a great question. I will say anecdotally, for the patients that we do have on GLP-1s, we haven't had issues with, I would say, psychiatric symptom management. While they're on the GLP-1s, we actually had some people improve significantly, which is a little interesting, but great question. I think something we should watch out for.
Awesome. Okay. Thank you. Yeah, pause here. I know we're getting close to the turn of the hour, but if anyone else has questions, please feel free to unmute or chat.
And we're always open. Like I think you may have our email addresses. If you have any burning questions that come up after this, we're both happy to answer emails and open up discussion if anybody's interested.
Absolutely.
Are there any system level changes you've made at your institution to improve outcomes with SMI patients?
That's an awesome question. So this is actually going to be a big part of my PhD dissertation, is assessing on a systematic level how we approach tobacco cessation in particular, because I feel like that's a big area that we can make a big impact, and that is very achievable. And then ultimately designing how we design a program to be more effective. So some institutions, even just broadly, have had more opt-out programs when people are inpatient for tobacco cessation. I know KU does that. And they've had a lot of success in achieving more sustained smoking cessation. I think just having the integrated care program here has helped open up conversation, and the practice has just, I think, organically changed. We would love to see a best practice sort of alert pop up in our EMR, but we have not been able to achieve that yet. And then ideally, as our program grows and we have more resources, we are really hoping to be the home for people in our institution for people with psychotic disorders, so that they automatically get referred to us and they have every resource and service that they need available right in the same location.
Fantastic question. I think a lot of the work that we've done has been more on individual factors and creating a culture of excellence, and then trying to kind of inspire those around us in our orbit to be part of that culture. So it's kind of soft power. There's certainly room for a lot of growth from an institutional organizational level.
So TBD.
Yeah.
Thank you so much.
Thank you.
Okay. All right. Well, yes, thank you again for your time this afternoon. Thanks for providing this grand rounds, and thanks everyone for joining. Hope you have a great weekend, and we will make sure to distribute the resources and contacts as well.
All right, thank you guys.
Thank
Have a
you
good
so
one.
much. Great
Sure.
weekend.